Hello, my name is Sadiq Omar Tayyib. Today, we're going to share with you the radiation protection in diagnostic radiology. We will start with the definition of radiation. Radiation is kind of energy transmitted or emitted in space in a form of waves or particles. Like gamma and X-ray are the wave part of it, and beta alpha are the particle radiation. Radiation started in even in centuries before uh, 460 BC. They think that the basic element of all the matter is a solid matter, but they cannot describe its component and until Thomson, Rutherford, and Bohr discovered the electrons and the nucleus. And in the modern quantum physics, they discovered that the electrons are moving in a cloud around the heavy part, which is the nucleus. So here we know exactly the components of the atom. It's containing of a nucleus, heavy nucleus, with protons and neutrons, and there's an electrons moving in orbit around the nucleus in different energy levels. If we dive deeper, we can see that the protons and neutrons are have small components inside. It's the quarks, and every proton or neutron have its own combination of the quarks type. Radiation particles and penetration. We have many type of radiation, as we said earlier. Gamma and X-ray are the same waves radiation, but not exactly coming from the same source. As we know, X-ray come from the X-ray tube, and the gamma ray produced in the unstable atoms. So if we see here, we can exactly clarify the penetration of each type of radiation. We have the alpha particles, and those particles are very heavy, and their penetration is limited. Like if we have a piece of paper, it's enough to uh, to stop them. Beta particles have a little more penetration ability, but the aluminum sheet will be enough to stop it. Gamma and X-ray has a higher penetration ability. That's why we use the high atomic number material like lead to absorb this gamma and X-ray or attenuated. The last most powerful type of radiation is neutrons. Fortunately, in the diagnostic range, the neutrons would not be produced because it needs energy more than 10 MV to be produced. And to stop this, we need around 25 centimeter of water or wax and boron. It's a combination shield to stop this neutron. So we don't have to worry about it in the diagnostic range. The types of radiation, we have two types of radiation. We have ionizing radiation and non-ionizing radiation. So if we see here the wavelength of ionizing radiation and non-ionizing radiation, we can see that the gamma ray uh, have the higher frequency and the smaller wavelength. And if we go down, the X-ray is the frequency is less, and till we reach the visible light. And if we go below the ultraviolet, then all this type of wide wavelength are non-ionizing radiation. So the meaning of ionizing is that the radiation the ability the ability to ionize the atoms of your body or the material it interact with. So if the photon or the energy is enough to kick an electron out of the external orbits of the material or the atoms, that called ionizing radiation. Let's go now to the most important part is the biological effect of ionizing radiation. As we see, the ionizing radiation could directly or indirectly damage your DNA, the cell's DNA. So as the radiation came in a form of electron, it's directly interact with the DNA if it's with the higher energy. So depend on the energy we can and the dose received by the mass, we can know exactly the type of interaction will happen. So first, if the electrons directly interact with the DNA, we call that the direct interaction of radiation, and this could cause a single or double streak in the DNA, and the single streak could be repaired by the DNA itself, but sometimes the double streak will repair uh, in a wrong way, and this may cause a cancer cell, and this cell will grow to a tumor. This is in a long period. So there's three possible action could happen if the radiation interact with cells. First, the cell will recover itself, which is a good thing. The other thing, the cell will die, and this is a good thing if we are treating tumor because we are using the same tool, the radiation. So if the radiation have the ability to kill the tumor cell, this is a good thing. A good thing, as we know, if it's a normal cell, then it's really gonna cause a cancer cell, and in a way or another. So the third option is that the cell survive, but in a mutated way, like as we say, the DNA connected to the wrong side, and then this will cause the cancer cells. Okay, here we can see a reduced sensitivity of the stem cells depend on the type of the cells, which is more sensitive to radiation, and the radioresistant cells. So as we see here, the muscles, brain, and spinal cord are the most radio-resistant uh, cells in our body. And as we see in the right, we have the lymphoid organs, bone marrow, and gonads, small intestines, and salivary glands are the most sensitive uh, cells in our body. So here we can see this the classification of radiation effect. So radiation exposure, as we say, ionizing radiation could directly affect a biochemical lesion or indirectly by producing something called the free radical. So radiation will interact with H2O, and it will give us H plus OH free radicals, and those free radicals will make the damage to the DNA. So the biochemical lesions have two types of effects. We have a deterministic effect and a stochastic effect. The deterministic effect is a lethal DNA damage, and it will cause a cell death or tissue malfunction and organ malfunctions. The stochastic effect, it's a sublethal DNA damage. It could cause gene mutation or replication of mutated cells. Okay, here we have a coronary angioplasty twice in a day, followed by bypass graft. Because of complication, the dose was equal to 20 gray, according to the ICRB 85. We can see here the effect of radiation, and as we see in the picture A, it's 6 to 8 weeks after multiple coronary angiography and angioplasty procedures. In B, it's 16 or 21 weeks, and in C, we see a close-up photograph of the lesion shown in C. The last one, A, we can see a photograph after skin grafting. Okay, the other important thing we need to discuss here is the unit we are using to determine radiation. If the radiation came from a radioactive source, it will be measured by Curie or Becquerel. If it's moving air, even if it's not from a radioactive source, maybe an X-ray tube or something, then it will be measured with Rontgen. So when it interact with our body, then we can measure it in REM or sievert, the most common unit used. And the if it's get into the body, then we can measure it in energy per mass, which is the gray and the red. Okay, here we can see the radiation effect. Like as we say, the eyes, thyroid gland, stomach, and reproductive system, skin, and bone marrow are the most places that interact directly with radiation. And as we see in the left scale below, zero point 0.1 millisievert is equal to a single chest X-ray. And if we have 2 millisievert, it will be equal to the average yearly background radiation dose in UK, for example. If we go up till the 20 millisievert is the maximum limit for a nuclear worker or a medical radiation staff worker. Till this dose, no symptoms and no detectable increase of having cancer. If you go to the orange middle at risk, if we see the 100 millisievert, it's equal to the level where the risk of having cancer is the first noticeable thing. And if we go up to 1,000 millisievert, 5% higher chancing of getting cancer. And this no immediate symptoms will be seen, but the increased risk of serious illness later in life. If we go up to the most dangerous area, which is fortunately we're not going to experience in the diagnostic radiology range, and 2000 millisievert is the acute radiation sickness. And if we go up to 10,000 millisievert, this is the fatal dose, and it will kill the personnel who absorb this dose within days. Potentially fatal radiation sickness and much higher risk of having cancer later. Okay, what are the sources of radiation in our life? We see here the medical X-ray as equal to 11% only of radiation sources, and as we see here, the other percentage of uh, radiation sources are not medical. So the biggest source of the human radiation exposure is the radon, which is 55%. And radon is a gas produced in a closed building with concrete. And that's why we recommend, if you are living in a building that uh, and using an only AC without a window and air replacement, we recommend to open and change the air inside the building to reduce the exposure from radon sources. While radiation cannot be seen and you cannot feel it, it can be described by a physical quantifying. We can quantify it or determine it by using an appropriate experimental setups, like we're using survey meters, for example, to measure it. Okay, now we go to the medical sources of radiation. So now we will take an example of the medical sources. As we know, there are sources of radioactive material, but here we can see the X-ray sources. The tube itself produces the X-ray, and 99% of the energy produced in the tube are heat, and only 1% is the uh, the X-ray. So the tube itself have some leaks. It's measurable, and it could be determined. The exposure will go in air, and it will be measured in milliroentgen. And when the patient dose received, it could be measured in millirad or gray. The main source of radiation or scatter radiation is the main source of dose to staff or radiographer. And as we see here, the radiographer dose could be measured in millirem or millisievert. Let's see here if we have a C-arm assembly, then we all know the camera, the imaging system, the intensify the patient table and the X-ray tube. So we will see now how we could be exposed to radiation in, this type of equipment. If we have a lateral X-ray tube, and this the tube is, as we see here, the X-ray tube uh, producing X-ray toward the lateral area of the patient. The higher backscatter region is, if you stand just beside the tube, then they will get the higher scatter. But if you stand behind, as the area which go here, the low scatter radiation area, the radiation received by the staff personnel or radiographer will be reduced. As we can see here, it's clearly shown here that the image intensifier, uh, the area below the couch near the X-ray tube is the strong backscatter region. So that's why most of the equipment have a lead shield on the table that to protect the staff from the this backscatter radiation. Let's take here an example of radiation. The X-ray tube produce like 25 Rontgen per minute, and when it's get out from the tube, it will interact with air and get attenuated till it reach 11 Rontgen per minute. And then when it interact with the skin of the patient, it reach the 3 Rontgen, and behind the patient, the dose will be zero point 0.1 Rontgen per minute. So this is the exposure of each area. Let's see here the three types or three setups for patient. The first one on the left is the borderline acceptable positioning. So the tube is under the table, and the imaging are quite far from the patient. The unacceptable positioning is to um, to increase the distance between the patient and the intensifier screen, and put the patient near the X-ray tube, which will increase the patient scatter to the staff. So the good position to have is to make the intensifier screen as near as possible to the patient, and reduce the distance between the X-ray tube and the patient to increase the interaction of X-ray with air and attenuate it. Here we can see the scatter of radiation depending on the position of the tube. So if the tube is below the patient, the uh, most of exposure or most of the dose will be below the table, and it will affect the lower part of the staff or the radiographer. As we can see here in the line, in the blue line, the dose rate without the lead apron. So that's why we use lead apron when deal directly with the patient. You can see here how useful this radiation protection equipment is. So if you see the red line, this will give us the dose rate behind the lead apron. So lead apron absorb like 90% of the dose, and the face and the upper part of the personnel will not get affected because the scatter radiation is very low. If we take that, the next position, when the X-ray tube is above the couch, the scatter radiation will be higher up, and as we know, all the lead aprons not for sure cover the face. And as we see here, the eye lens and the head will take more dose than at the left side. Okay, now let's take a look to the fundamental principles of radiation protection. We have three basic principles: justification, optimization, and dose limitation. Uh, Justification: no practice shall be adopted unless its introduction produces a net positive benefit. And the optimization: all exposures shall be kept as low as reasonably achievable. The third one is the dose limit. The dose equivalent to individuals shall not exceed the limits recommended for the appropriate circumstances by the ICRB, which is the International Commission on Radiological Protection. The basic radiation protection strategies to reduce dose to staff is the time, distance, and shielding, which call the A.L.A.R.A, as low as reasonably achievable. If we reduce the time, if we increase the distance, if we increase the shield, we will get to the result of reduction of radiation exposure. The most important law to know is the Versus square law, and this law is that if you increase the distance from an X-ray source to 1, the intensity of the radiation will reduce to a quarter. And if we increase it to 3, then it will be the intensity will be increased by 1 over 9. Okay, this is an example of the radiation near the C-arm, as you see here, and the tube is below the patient, and the head area is 4, the chest is 12, and the pelvic area is 36. If we move to 1 meter, then the dose will be only 3 roentgen per minute. And if we go to 2 meters, then it will be 0.75. And if we go to 3 meters, this will reach a 0.33. So what we know here is that the dose will reduce if we increase the distance. And 1 meter is enough to reduce the radiation to a quarter. Okay, shielding. The personal shielding is a very important thing to know, as we know that lead aprons and thyroid and gonads are all protective equipment. At least we should wear a 3 or 5 millimeter. And if you want to order a new lead apron, I think it's better to contact the radiation protection unit to specify which thickness is good for you. Unfortunately, now all the lead aprons are lead equivalent material, which is very light to be wear. Um, the lead apron should be checked every year uh, to to detect any cracks or gaps or damage in the lead aprons to be changed. And This lead aprons uh, should be reported to radiation protection unit every year. Sorry. The A.L.A.R.A policy here for the technician is to have the correct exposure factors to your patient, have a correct radiographic techniques to the patient, and appropriate radiation protection to yourself, and appropriate development and viewing techniques, and you should have as well appropriate radiographic position for examination, and to minimize as much as possible the repeat of examination, and to be educated with all the updates on how to protect yourself and the patient. Okay, now we go to the TLD part, the thermoluminance detectors, which is the individual monitoring devices and exposure assessment. Individual dose monitoring shall be undertaken for workers who are normally exposed to radiation in controlled areas, like radiologists, medical physicists, the radiation safety officers or radiation protection officer, and radiographers and nurses. Other frequent users of X-ray systems, such as endoscopists and anesthesiasts and cardiologists and so on, as well as ancillary workers who work in a control areas, shall also be monitored. These types of TLD could be used: the finger dose or finger dosimeters, the wrist badge, and chest badge. As we see in the left side here, this is type of TLD for chest, and the finger badge to the people who will interact with their hands with the in a radiation field. Individual monitoring when a lead apron is used. So where to wear your lead apron if you are wearing that apron. The dosimeter should be worn under the red apron, so it will give us the real dose of your body. Because, as we say, let everyone reduce the dose to 90%. So if you wear it outside, that means this is the dose received by the let everyone, not your real dose. And in some cases, like the worker who work in a high workload, like interventional radiology and cath lab, uh, add an additional dosimeters outside the lit apron should be considered, and by the radiation safety officer, they will give him an extra neck TLD to measure the extremities dose, like head and hands and legs. The radiation exposures in pregnancy. There are radiation-related risks through pregnancy which are related to the stage of pregnancy and absorbed dose. So, if pregnant staff, uh, the radiation exposure in pregnancy increase the risk are most significant during organogenesis, and in the early fetal period, somewhat less in the third trimester and least in the third trimester. Like the most risky the early period of pregnancy, and it will get less and least when the weeks of the trimester increase. The radiation exposure in pregnancy. If the staff personnel gets pregnant, she should notify the radiation protection unit and fill the pregnancy form to be monitored monthly during the pregnancy period. The maximum dose for each abdominal and chest TLD should not exceed 1 millisievert per pregnancy period. If it's approach this limit, she should stop any X-ray imaging procedure and transfer to another duties. As we can see here in this image, she will have two TLD, one for chest and the other one will be in abdomen area to measure the dose received by the fetus. Okay, here we have the last thing. We need to know a very important thing, the dose limit. How much radiation could I receive and be safe? The effective annual dose is, according to the ICRB, it's 20 millisievert, and we have another protocols, but we are using the ICRB 60 protocol in Saudi Arabia. So the effective dose annual uh, is 20 millisievert for staff, and the effective dose accumulated in 5 years should not exceed 100 millisievert. The equivalent dose for the eyes, lens, and skin, hands, feet. The eye and lens it should not exceed 100 millisievert, and the skin, hands, and feet should not exceed 500. If the staff is pregnant, should not exceed the 2 millisievert, and we measure it by giving the staff 2 TLD, one for the abdomen area and one for the chest. If we have public and radiation department, the effective dose should not exceed 1 millisievert, higher if needed, provided 5 years annually. Average should be less than 1 millisievert. That's why we are checking all the X-ray rooms yearly to be sure that the dose outside this room will not exceed the 1 millisievert. And the equivalent dose annually for the public 15 millisievert for lens and eye and 50 millisievert to skin, hands, and feet. Thank you very much for your attention.